TopMedTalk.
So I think as a starting point, it would be great if you could all, one after another, give us a 50-second summary of the main points from your talk for those in the audience who haven't had a chance to review the whole talk as yet. So starting perhaps with you, Dan.
Good morning. So just very briefly there, just to summarise the talk, we all give oxygen during the course of anaesthesia and after surgery. Quite naturally, we're all quite nervous about the prospect of patients becoming hypoxemic and the issues that may lead to. So we tend to give a little bit more oxygen than is necessary in a sort of prophylaxis way to prevent people from becoming hypoxemic. And the natural tendency there is to give quite a lot more, leading to hyperoxemia. There have been a number of studies over the last 20 years to actually therapeutically use hyperoxemia to try and reduce surgical site infections. And over the last 20 years, there have probably been about 20 or so different studies looking at this, accompanied by a further 20 or so systematic reviews and meta-analyses. I think it's fairly reasonable to say that we're not really sure where we are at the end of that 2-decade journey looking into how much oxygen we should give to patients during the course of surgery. The pendulum has kind of swung backwards and forwards during that time between higher and lower concentrations of oxygen. I think if we were to look at the balance of evidence today, it very slightly favours the higher oxygen concentration group, so giving approximately 80% oxygen during the course of surgery and for up to 6 hours after surgery, to reduce surgical site infections. But the jury is really out and it's changing very rapidly. The largest study to date is about 1,400 patients, so the largest randomized controlled trial. So it's clearly an area that we need to look further into, as we're not really sure where we are yet with how much oxygen to give during the course of surgery.
Thanks, Dan. That's a very clear summary. And then moving to Helen, could you summarise your talk for us?
I talked about the possibility of applying a different nutritional approach to trying to reduce the harm that comes as a consequence of the metabolic stress imposed by surgery. So we know that individually and collectively, tissue injury, immobilization, and fasting and reduced oral intake around the time of surgery all collectively trigger a catabolic response and insulin resistance. And together with causes protein deficit and hypoglycemia, which we know has problems for tissue repair and immunity. Our current approach is to try and tackle this problem by supplementing nutrition in the perioperative period, and in particular to try and identify those people who are at even higher risk of this metabolic stress, so the malnourished patients who make up a big proportion of our surgical patients. But I talked about a different approach, which would be rather than trying to supplement supply, which doesn't work in all cases, whether there was any potential to use what we know from animal models of dietary restriction, where we could change cell response to stress. So we know that dietary restriction triggers lots of intracellular signaling cascades, which would mean that on many different levels, the human body is better able to adapt to lots of the different stresses encompassed by the surgical stress response. So I talked about the evidence that we have for that from animal models, some caution in terms of how we might apply this to human patients, and some of the key questions that we would need to work out to take this further. So in terms of how we would dietary restrict, how long it would take, how feasible it is, how safe it is, and whether it can be done using things like specific depletion of diet from specific amino acids, and or timing fasting and feeding to particular times of day.
Great, thank you, Helen. And finally, Tim.
So I spoke about fluid and hemodynamic monitoring and how we can manage our fluid and hemodynamics during the perioperative period, and really asked 4 questions during the talk. Firstly, how much fluid should we give? And what about blood pressure management? And what about goal-directed or advanced hemodynamic management? And finally, are there any advantage of colloids over crystalloids? So we start off briefly with the first question, how much fluid should we give? Again, I think Dan mentioned the pendulum. The pendulum have definitely swung in this area. And the advantage of this area, and talking about this area, is there has been a number of large studies recently, which is great. So in this area, 15 years ago, we realized that the liberal use of fluids was harmful. Giving 6-7 liters of fluids during surgery, particularly major abdominal surgery, was harmful. And then during enhanced recovery era, people started giving less and less fluid. Restrictive fluid management became popular. And then some signals in observational studies started to show that perhaps we were getting too restrictive and we were causing harm, particularly to the kidney with acute kidney injury. So the RELIEF study came out, a large 3,000 patient study published in the New England Journal, showing that this was indeed true. Too restrictive was harmful for the kidney. And we swung the other way and now advocate 1 to 2 litres positive. Moderately liberal approach is probably the sweet spot. With regards to blood pressure management, a lot of observational work showing that hypotension is harmful, and just one really large major randomized controlled trial. So again, the evidence currently is you want to keep the mean blood pressure greater than 65 and probably higher in patients with pre-existing hypertension. With regards to gold-rated therapy, again, a lot of studies in this area, and we'll probably come onto it in the discussion. It's generally advocated as recommended for major surgery, particularly in high-risk patients. And the important thing, I think, is that we need to optimize our fluids first, and then if the patient is still hypotensive, add a vasopressor to optimize our blood pressure. And finally, which fluid should we use? There's been, again, a lot of debate about this over the years, and the current evidence of benefit of colloids is decreasing. Recent large 1,000-patient study in anesthesiology comparing crystalloids and colloids using gold-rated therapy showed no difference. So the evidence of benefits of colloids is currently weak.
So I know, Mike, you had some thematic questions you wanted to start the session with. So should we start with those before going to Slido, which is beginning to hot up?
Thank you, Dennie. We kind of thought this through when we put this session together. It's one of the intriguing things of all three interventions, so fluids, oxygen and nutrition, are certainly in volume, in amount, they are the biggest interventions we give. And that's a sort of common thing we tell ourselves in relation to fluid and oxygen, but we probably talk a little bit less about nutrition. And I guess the three interventions also sit at different points in terms of our level of confidence in the amount of evidence available. And Tim, as you said, there's quite a lot of evidence from big randomized controlled trials about fluids, so we're confused at a relatively high level. The oxygen story probably lags behind that for reasons we can go into. And the nutrition story, although there's a reasonable amount of perioperative nutrition literature, as you acknowledge and emphasise in your talk, Helen, I honestly don't think we've thought about it that much. And Enhanced Recovery encouraged us to feed people as close to the initiation of surgery as possible and to get them feeding afterwards. Was that the right thing? I know we're talking speculatively because of lack of data, but what if you had to have an operation or someone close to you had to have an operation, what would you recommend?
The thing I'd be very keen to reinforce is that I don't think that the two are mutually exclusive. So I think that all of the literature that kind of encourages sort of physiological feeding and sort of backing up a cause remains important and evidence-based. I think that the addition, and I think it would be an addition, of trying to optimize cellular signaling in the same way that we do with exercise, but combining it for looking at the potential for improving cell strategies, it would be an addition. So I think it's more of a more nuanced way of thinking about nutrition as opposed to just what goes in. I think it's about how we time what goes in to utilize the kind of pro-survival signaling that you get from fasting while not encouraging people to be malnourished. Because I think the two can fit together, as you alluded to. I think we've not really investigated the potential benefits that we get from fasting.
So someone is not familiar to this literature, but for example, we have a great interest in rehabilitation, and we talked a lot about that yesterday. Simplistically, the avoidance of excess calories and the intermittent fasting, is that something that could be done in the preparation for surgery phase along with different types of exercise strategy, and then you'd maintain nutrition through surgery, even feeding patients during surgery, or is there a place for a starvation stimulus during the immediate perioperative phase as well?
My instinct would be that if you're trying to improve an adaptive response it has to be beforehand. So I think that the intermittent fasting would fit as a natural part of a prehabilitation strategy, along with exercise programming in the same way. And I think that in the perioperative period, there still has to be a thought about how we provide nutrients that are required for repair and immunity. I think it's more at the deficit of when the metabolic stress is not simply a consequence of a nutritional deficiency, it can't be corrected purely by nutrition. But I think it's about trying to use the preoperative period to improve stress resistance to the surgery whilst not malnourishing the patient.
And then when we get into the surgical phase, is it going to be bad to do it then? I mean, so again, my simplistic approach is that you kind of feed them all the way through, and the ideal might be pre-op drinks right up to the start of surgery, get an NG tube in, feed them during surgery with insulin, and then get them eating as soon as possible afterwards. Is that the right thing to do, or is there even a place for some kind of starvation stimulus at some point in that shorter period?
We don't know very much about the possibility of post-conditioning with the intermittent fasting. So I think that we know that it has the potential to ameliorate the stress when you've had this program beforehand of acclimatizing the person to a stress that is planned. I think that trying to introduce it during the period when the stress is already happening and overwhelming, I'm not sure what the effect would be. And I think that trying to keep what we know to be effective, like our carbohydrate preloading, our feeding early, our minimizing starvation period, all of that will also reduce the stress itself. So you can both reduce the stress and increase the stress tolerance.
Got you. And I think you've also offered me a little hook to move on to Dan, having said acclimatization. So Dan, you're a long history in oxygen research, both clinically but also the high altitude work you've been involved with. Helen's talked about the preconditioning through intermittent starvation. Is that something, as part of the oxygen story, we should be thinking about? I've seen it out there in literature a couple of times in the last decade or so.
Definitely. It's certainly something we've been thinking about more and more from a research perspective now, as to whether the use of intermittent hypoxia, or almost paradoxically intermittent hyperbaric oxygen, may have a role in priming the system before surgery, both of which, again, paradoxically, can lead to the same sort of cellular effects through mechanisms largely based around the release of reactive oxygen species. And these are certainly modalities that we need to think about in the whole oxygen story. So using intermittent hypoxia, for example, in a similar way that exercise might be used prior to surgery, bursts of just moderately low hypoxia, breathed perhaps through an oxygen mask or in a chamber type situation in a sort of 2 or 3 week period running up to surgery, for sure.
I guess where you're going in Plymouth, there's opportunity to do that. So we look forward to seeing papers at EBPOM next year.
There definitely is, and it's certainly very, very strong in our minds at that moment, and we've already made some headway already to try and set up studies, first of all, to look at this in healthy volunteers, and then move this into a more clinical sphere to test this out. And I think it might, to some people, sound a bit alarming, taking patients and making them hypoxemic prior to surgery, but certainly it works in other areas. It's a technique that has been used extensively in elite athletes training for Olympic Games type situations, for sure. So that we may be able to glean a lot of information and benefit from that approach to preparing people for a big event.
And is there a direct link with the more or less story in terms of hyperoxia, hypoxia, normoxia during surgery? I mean, could you acclimatise patients? Is that what you're thinking, or this is a slightly different thing?
I think it's quite possible, and certainly in the physiological world, there's a very interesting component of acclimatisation, is this sort of cross-acclimatisation, whereby you could, acclimatising to one modality, such as hypoxia, may acclimatise you for other modalities, such as hypothermia, for example. So there may be common cellular pathways triggered by extremes of physiology. So we may see situations where acclimatizing to hypoxia, for example, doesn't only just get you ready for hypoxia, but may get you ready for a big reactive oxygen species or inflammatory hit that is commonly associated with surgery.
And if I bring you back from the more speculative to the clinical, sort of same question as Helen had originally, what if you or someone close to you was undergoing surgery, what would be your oxygen plan?
I think that's really difficult to answer at the moment for the reasons that I alluded to during the talk and in the short summary at the beginning, which is that I think it would be fair to say that we're in a bit of a muddle at the moment with regards to the evidence base. The original early studies 20 years ago showed that there might be benefit in receiving a higher amount of oxygen, typically 80%, to reduce surgical site infection. Other studies have failed to show that, including the largest study over that 20-year period. There's also been some difficulty with the literature that's out there. Some of the papers have been retracted, some of them have been accusations of scientific fraud, and varying conclusions from different systematic reviews and meta-analyses from this sort of 80 versus 30%. And I think ultimately the answer is going to be a bit more nuanced than should we give you a very large or very small amount of oxygen when you're undergoing surgery. And there may well be an individual need for titrating oxygen to a target, but what that target is, it remains unclear. So go back to your question, if I was having surgery tomorrow, how much oxygen would I ask the anaesthetist to give me? I really don't know at the moment, and it's sort of crying out to be answered as soon as possible.
So I'm not trying to get you in trouble with this question, but I'm going to ask it anyway. Recognising that uncertainty, you know, I'm both familiar with the WHO guidelines around surgical site infections and the assertion that there was no mechanistic plausibility for less oxygen being of more benefit, and that was essentially his commentary on the proxy trial results, which did suggest, albeit in secondary outcome analyses, that there might be benefit in both in cancer patients and in relation to cardiovascular risk. What's your view on that statement? It's
somewhat unusual to say that there may be no biologically plausible explanation for a benefit in giving less oxygen rather than more. And I think the harm from more, if you like, to turn it almost inside out for a moment, is this genuine concern that giving more rather than less oxygen may cause harm to the lungs. Certainly we know from animal studies and a very few human studies that giving high concentration oxygen for several hours causes a release of reactive oxygen species in the lung parenchyma, leading to harm to the lungs, which would result in a perioperative situation in post-operative pulmonary complications. Now, I think it's fair to say that the literature is not strong in this area. It is certainly biologically plausible. There is some evidence to support this, but most of the studies undertaken to date have not been designed to look for this. So they look at pulmonary complications as a secondary outcome. So they were never powered to look at them in the first place. So it's not surprising that they often don't find them. So you would need a large trial that was suitably sized to pick up both the potential harms and benefits from both groups that you looked at, or even start looking at ranges of oxygen across studies. So I think it's wrong to say there's no biologically plausible mechanism for giving less oxygen to be beneficial, but have we got the evidence to firmly say I don't think so at this stage.
It's a very diplomatic answer to a slightly naughty question.
Yeah.
Thank you. Before we jump over to slide, I'm just going to ask Tim a couple of questions on the fluid front. Again, the same opener. If you or someone close to you was having, and in this case, not so major, sort of moderate surgery, elective cholecystectomy in someone of less than 50, for example, what would you do in terms of fluids?
I think the RELIEF study has made the answer a lot clearer. I think that it's great, as opposed to nutrition and perhaps oxygen, that we have large randomized controlled trials in fluids and hemodynamics, which is hopefully where we should aim for all aspects of perioperative medicine. So the RELIEF study, for those who don't know it, did show that being too restrictive of your fluids was associated with acute kidney injury. And we always known it's a kind of U-shaped curve with regard to fluids, and I think we've now got evidence this is the case. So aiming for about 1 to 2 litres positive seems to be the sweet spot. So that's what I would do in someone who's 50 having a surgery that you were describing. I would give them 2.5 litres of fluid during the procedure, and then make sure I keep their mean arterial pressure definitely greater than 65, depending on their pre-existing blood pressure.
So the obvious next question, given what you've written about in the past, is goal-directed fluid therapy or not in that individual?
I think not in this individual. I think goal-directed fluid therapy has been shown to be beneficial, but it's obviously the greatest evidence is in the highest risk patient. In this kind of type of patient, unless there are any complications, I don't think it would add any benefit. And I think that's been borne out in the literature, as you say, it's not surprising adding advanced technology is beneficial in the higher risk patients. So if this patient, relatively low risk, relatively straightforward surgery, I think you could just aim for 1 to 2 litres positive as I've described.
And if I challenge you and said, but surely the reason we don't show an effect in clinical trials is because the marginal benefit is going to be so modest that your sample size would need to be huge to see that effect. Why isn't the biological plausibility that the same effect is there, just less? Why are you not giving this person goal-directed fluid therapy, being a devil's advocate?
Yeah, I think the surgery you described is relatively straightforward, and we've got to look at resource allocation. You could say that you were going to do goal-directed therapy for everyone. You could have goal-directed therapy if you're having a toenail removed, but you've got to allocate your resources appropriately, and definitely the evidence suggests that the greatest benefit is in the higher risk patients or higher risk surgery.
So in part it's about sensible allocation of resources rather than necessarily knowing that there is no effect at a particular level. I don't know whether there is or isn't an effect, but you'd have to argue a different sort of biology in that situation.
Correct, but also goal-directed therapy I think is about giving you information to be able to intervene when there's episodes of hypovolemia earlier to avoid hypotension. And again, in a patient having relatively straightforward surgery, you're unlikely to get significant hypovolemia. So if you don't get hypovolemia, having information to be able to correct it sooner is not going to be beneficial. So again, it's selecting surgeries where you think there's going to be hemodynamic compromise, and advanced technology could perhaps assist you in avoiding those episodes of hypovolemia.
So this is very consistent with the risk-adapted matrix you've talked about in the past.
Yeah, exactly.
Yeah. Dennie.
There's a lot of questions building up on Slido. So actually, firstly, another one for you, Tim. Is there any evidence for the use of noradrenaline over metaraminol or phenylephrine in the peri-op post-fluid optimization control of blood pressure, sepsis aside?
Complex question. There's a lot of, perhaps, should I say, plausible physiological benefits of doing that. And we've debated this at consensus conferences. And if you had to say what would be your ideal vasopressor to use, I think noradrenaline, norepinephrine, as a lot of experts would say, that would be their choice. Physiologically, it adds a little bit of beta as well as alpha, so it's not a pure alpha agonist, so that could be potentially beneficial. The IMPRESS study, which is the only randomized controlled trial of individualized blood pressure management, did use noradrenaline and norepinephrine as their vasopressor, and some centers have started to use it, particularly dilute noradrenaline, norepinephrine peripherally rather than phenylephrine. Are there any large randomized controlled trials comparing the two? No. So we don't know. I think it's a very interesting question. A lot of centers have started to switch over, but largely there is no evidence, and I think that's a trial that needs to be done.
And the follow-up question here is, how do we best interpret cardiac output monitoring in major laparoscopic surgery with steep position changes such as head up or head down?
Yeah, another complex question in a way. And I think laparoscopic surgery is challenging. And we've done some simulation of this. I've done with Monty and others looking at this. And I think perhaps the best approach, if you're going to do goal-directed therapy in these patients, is to really optimize the patient initially after induction of anesthesia with fluid boluses to make sure that they optimize their stroke volume before you start the pneumoperitoneum or going steep head down. If you are then going steep head down, it's very unlikely in that position you're going to have a lack of preload. You're effectively doing a leg raise, you're putting the patient's legs in the air. It's really a heart failure model because the right heart, if you've got any right heart strain, you're going to have a heart failure model with all that preload that you're getting during the steep head down. So during that time, it's unlikely that you're going to need more fluid unless there is significant blood loss, and it may be that you would need a little bit of gentle inotropic support, if anything, if you have any cardiac dysfunction. And then we recommend that when the surgery is finished and the patient's flat again, the pneumoperitoneum's let down, that's a good time to really re-optimize and make sure that your stroke volume is optimized again at that time. Because again, once you go head down, you lose that preload. It may be that the re-optimization is needed at that time. But undoubtedly, it makes the physiology a lot more complicated with laparoscopic surgery.
Thanks, Tim. And then a couple of questions for Helen. I managed to delete the last one, so the exact wording I've forgotten. But it was along these lines, and there's some themes, having read through several of the questions. First of all, the intermittent fasting data and its effect on metabolic stress from the animal literature. Were all those animals nutritionally normal, as in replete, i.e. not malnourished when we did the fasting?
They use lots of different models, basically. So they use models where they start off with, like, water depletion, and then they test ischemia reperfusion injury. They do ones where they make the animal sort of nutritionally deplete and then gradually add back in different amino acids, proteins, lipids, calories. And I think the key would be to say that even in the literature, we find that the types of malnutrition are probably quite important. So when people say malnutrition, it's quite a generalized term. Malnutrition could refer to obesity and metabolic dysfunction. It can refer to the kind of sarcopenia, muscle loss that happens with inactivity and aging, and it can relate to those related to inflammation that we see in heart failure, renal failure, cancer. So I feel that there's the kind of the long-term effects of dietary restriction are particularly effective in reversing things like metabolic dysfunction and the effects of aging. So I feel that for particular forms of malnutrition, they might actually be useful in reversing things that no form of nutritional therapy has been able to. So sarcopenia and cachexia are not reversible, whereas sarcopenia can be delayed but not prevented. So that's a brand answer to say that they have lots of different models. Some of them have induced a longer-term form of dietary restriction, but I'm assuming in an animal that started off nutritionally normal. But also that the effect can be induced in a very short time period, so literally less than a week.
Less than a week. Okay. So I think that was one of the other themes that had come from this question, which was balancing. So yesterday we heard a lot about preoperative nutritional optimization, and I think one of the sort of agreed consensus was it's slightly the Cinderella in prehabilitation at the moment. Certainly looking at UK practice, although we all think it's important, we're not actively screening for malnutrition. And really what you appear to be saying here is that actually the diagnosis of malnutrition is a bit vague in itself, and we need to look at the etiology, and then that our intervention may be different, because people are concerned that they've been told to protein load and to treat malnutrition in the prehab period, and how do they balance that with the advice to intermittently fast? I think you've covered some of that.
Yeah. I think that basically in some of these models, some of them will involve with calorie restriction and protein restriction. Some of them will have supplemented the fact that there's specific protein restriction with balancing out the calories from other nutrients. I think I don't have the answer to the question as to how we do it safely yet, but I think it may just be the easiest thing at this point would be to maintain the same nutritional intake as for nutrient supplementation, but reduce the time frame in which it happens. You have your fast periods and your feeding periods.
Helen, so whenever I hear anybody say metabolic switch from one, for these various stimuli, it makes me wonder whether actually there's an easier way. And we get this in the prehabilitation exercise literature. For those who can't or won't exercise, can you achieve the same through a drug, for example? Do you think that's possible? And if so, what are the candidate pharmacological interventions we'd be looking at?
So a lot of work has been done on the specific signaling pathways that the dietary restriction is activating. And so the key pathways are things like AMPK, mTOR, and hydrogen sulfide signaling. So they have done some work in terms of specific drugs that are known to modify these pathways that do work for models of ischemia reperfusion injury. So there are definitely potential candidates as we begin to work out what the signaling pathways are that are effective. So that this whole ream of downstream effects, and then there's the signaling pathways, and then there's the nutrient energy intake. And I guess what I would argue is that it may be easier to just take out a specific thing that we're eating. It may be easier to eat a diet that's deplete in methionine for a few weeks than it is to take something that interferes with a pathway that has lots of effects on cell growth, cell proliferation in a group of vulnerable patients. But I think pathway is clearly really important.
It sounds if you have a type of malnutrition that's caused by simply not eating enough, so for example, a duodenal obstruction, it may be that food is what you need, but with other types of malnutrition, it may be a primary metabolic disorder, and that we should start thinking about treating the underlying disorder. And those might be the type of patients that might benefit from fasting rather than a blanket intermittent fasting for all. Another question about the fasting was, should it be during the day or overnight? Do we know? And how long for?
Well,
and how often?
How often? So I think we don't know yet. So I think we know that it has to be, the signaling is produced by a collective series of changes that happens when you don't take any food in for sort of 12 to 14 hours. So I think for the full effect of switching on that signaling, it would be a fasting period of 14 hours. So I think just long enough that you deplete your glycogen stores, start producing ketone bodies, and start changing your insulin signaling. So collectively, these changes are what's triggering the cell to say, we need to get ready for more stress. We need to change the way that we're producing energy. We need to change our antioxidant defenses because there are problems ahead. I mean, it's potential you could also activate it using a ketogenic diet, because that mimics a proportion of those changes. And so in terms of whether it's better in the day or at night, I don't know. So I think we know that eating at night causes stress, which because our metabolic pathways aren't set up to process those pathways at night. And that has been linked to metabolic dysfunction. And I suppose there is a natural state of us not eating at night, which maybe the key is to just eat slightly less in the day. Because I'm sure our ancestors were not eating continuously or being fed continuously via nasogastric tube.
Right. And along those lines, another one, this is from Karen in Sheffield. Are we in a position to grade surgery by the metabolic demand so we can match the right pattern to the right magnitude of surgery for the best outcomes? It's a big question.
Is this for me again?
Yes, I think so.
So we know that the metabolic load that's imposed by the tissue injury is directly proportional to the amount of tissue injury. So if you're having a big open surgery with lots of tissue injury, you will definitely have a higher metabolic load for that. In the same way that if you use regional techniques or if you minimize the surgical stress in other ways. So I think that potentially we will be able to grade it such that you need a longer period of metabolic preconditioning, a more intensive period of metabolic preconditioning before open surgeries.
It's a great question, but it raises that spectre of the slightly more complex question than more or less, which is to who and individualization. So I'm dying to go and ask Dan a question about the oxygen work because of our understanding of what happens to people at altitude. So we know there's this huge spectrum of sensitivity to hypoxia, if you like, or hypoxia tolerance. So should we assume that our patients have that same spectrum of physiology, and therefore, rather than have we got it all wrong thinking high-low, should we be targeting specific levels of oxygen at specific patients, and if so, how?
Well, I think you're absolutely right. And the problem that we're in at the moment is this dichotomy between should we give 80% or should we give 30%? And the reality is that we just sit on the fence and give 50% in most of the studies that have looked to see what we actually do in our day-to-day practice. So we don't do either of those two things generally. But it would be a massive oversimplification of human physiology to expect that the right amount of oxygen would be one of these three values. And as you rightly say, it never ceases to amaze us when we look at the physiology of people ascending to high altitude where there's a lack of oxygen, just the vast array of responses that you see in front of you in terms of acclimatization, adaptation, and failure to acclimatize well in people. And you see that in a way that's unpredictable. So it's not the younger, fitter people that tolerate low levels of oxygen best. So there's no reason to suspect that this is not exactly the same in patients who are going to undergo their own kind of ascent of Everest, if you like, in the form of major surgery. How we tackle this is really unclear. Oxygen is a drug, and usually when we bring new drugs onto the market, we do pharmacokinetic studies and we sort of titrate dose and response and look at harm caused by different doses of drug. But we never did this with oxygen because we think we know everything there is to know about oxygen, and paradoxically, it's probably the drug that we know the least about, yet give the most. And you'd almost have to wipe the board clean and say, let's start a series of physiological experiments in patients looking at a dose response in both benefit and harm. But that is a huge piece of work to undertake. But it's probably what we need to do at some point in the future, because I think even if we did the very large multi-center randomized control trial to try and get to the bottom of is giving 80 or 30% oxygen better, it's not going to be one of those two that necessarily is ultimately right for the individual patient in front of you. It's a massive problem that we sort of still have to face, and thankfully will provide us with a lifetime of research, I've no doubt.
Tim, I'm going to jump back to you, and you're kind of off the hook in a way, because we already individualise some aspects of fluid therapy in terms of volumes administered. Goal-directed fluid therapy we touched on already. What about individualising? Say we've got the flow bit and we've got the blood pressure bit. Where are we on individualising blood pressure targets?
Yeah, perhaps not as advanced as we are with fluids. So there's really been two approaches to blood pressure, I guess, in the literature. And a lot of this work has come out of the Cleveland Clinic looking at their database on blood pressure. And they looked at hypotension in two different ways. It was just looking at a mean blood pressure less than 65, and then looking at a change from baseline. And when you look at baseline, it's very important that you get an accurate baseline. And the best way to get a baseline blood pressure is a 24-hour ambulatory blood pressure monitoring. Not many patients have that. Some do. It's increasingly done in primary care. But if you don't have that, you want an accurate baseline not on the day of surgery. And then you can look at 20% changes from baseline. And when they did this at the Cleveland Clinic, they actually found the results were fairly similar between the two groups, that both had an inflection point either when you went less than 65 or less than 20% from baseline, with an increase in myocardial injury after non-cardiac surgery, or MINS, and AKI. So the recommendation, they decided to recommend a mean of 65 just because it was the easier to measure, and that's what's gone into a lot of the guidelines, including the POCI guidelines. However, you could argue, particularly in patients who've got significant pre-existing hypertension, that maybe we should individualize and we should aim for a higher blood pressure. That's what they did in the IMPRESS study. As I mentioned, published in JAMA, they aimed for a mean blood pressure within 10% of normal in the intervention group, and that was shown to have benefit. So we don't know, again, is the short answer. Definitely avoiding mean pressure less than 65 should be our number one goal. And then in patients with pre-existing hypertension, it may be beneficial to individualize more, and it is undoubtedly a question that needs to be asked. The IMPRESS study was I think around a 200 patient study. So we haven't got a lot of large randomized controlled trials in this area, and we definitely need that moving forward to help answer that question.
And on the goal-directed fluid therapy bit, we can give less if we give colloids, but we have this ongoing controversy about whether colloids are harmful. The critical care community have largely persuaded themselves based on high-dose studies that they are. Where are we in the perioperative setting, given that many of the goal-directed fluid therapy studies, which is, I think you've said is generally a good thing, used a colloid for their fluid boluses that were guided by a cardiac output monitor?
Yeah, again, obviously an area of controversy, and you're correct. Almost all of the goal-directed therapy studies have used colloids. And I think we know now from a lot of the work in critical care that you do need less volume if you give colloids, but it's probably not 2 to 3 times less. It's more about 1 to 1.6 probably with colloids versus crystalloids. And in the perioperative arena, there's no real evidence that colloids cause harm. I think that's different to critical care. And studies that both looked at starch and more recently at albumin have not shown any harm. The question is there any additional benefit with colloids? And I think that's where we're starting to get large randomized controlled trials. To say the study published in Anesthesiology was done by the group from Cleveland Clinic, and they had a goal-directed therapy protocol in both groups. Both had a sensible background of crystalloid, and one used boluses of colloids, one used boluses of crystalloids. Overall, they had around 3 litres of fluid, 3 to 4 in both groups. So again, the sort of range that's recommended after the RELIEF study. And there was absolutely no difference between the two groups in terms of outcomes. One other study, which used an automated fluid management, so use a closed loop system. Again, background crystalloid, colloid or crystalloid boluses. Smaller study, around 200 patients, did show a benefit from colloids. So the current evidence is no harm perioperatively, but the evidence of benefit is weak. We still use some colloids, and I think the Cleveland Clinic study needs repeating before we completely get rid of colloids. Definitely the evidence of benefit is decreasing as some of this literature is published.
Can I just ask here, because there's a very popular question on Slido for Tim around blood pressure again. It says, Tim, the results of ICNARC 65 suggest targeting a mean pressure of more than 65 in vasodilatory shock had no benefit and may in fact cause harm. How does this fit with your recommendations?
I think very different population. You must remember, again, in this area, a lot of the literature is observational from databases. Being observational, obviously, it's a relationship between hypotension and harm. We still need large studies, but it does seem to be quite a clear association in literature that when you get to a mean less than 65, perioperatively, acute kidney injury and MINS both increase. And obviously, being observational, you can say that sicker patients are more likely to get hypotensive, sicker patients are more likely to have adverse outcomes. So it is, most of the literature is an association, but that being said, it seems to be quite a powerful association. So most of the groups are putting out consensus statements and guidelines, including Hoki, have taken this literature and think that it is reasonable to target a mean greater than 65. And I think the important thing as well is to note that and when they've looked at these hypotensive events, 1/3 of these are between the induction of anesthesia and incision. And we know that this is an area where hypotension is common. This is an area directly under our control. And I think that we should be vigilant to try and reduce episodes of hypotension as much as possible in this area seems prudent.
Back to Dan for some more questions along the lines of really what Mike was asking earlier. So it's about what we should be targeting perioperatively in terms of SATs. So I've taken to prescribing, this is from Graham Walker, oxygen with 88 to 92% targets. Am I wrong? Should we be avoiding SATs over 98? And somebody else, which is another popular question, saying, well, now we've got used to everybody having SATs in the 80s with COVID, surely 88% is enough.
The first thing to say, similarly to what Tim's sort of said, is that you have to think about ICU and perioperative medicine in a very different ways. One describes the acutely unwell and the other is basically a person who is well but maybe multi-comorbid but is about to undergo a known stimulus. So for sure, over the last few months around the world, we've been used to seeing people with very low levels of oxygen, and we were happy to tolerate low oxygen saturations in those patients. I guess what we don't know is whether that improved their outcomes or made their outcomes worse. We may well have been happy to tolerate them, but because this wasn't done in the format of a study, it's impossible to say whether that was the right thing to do. Recently, there's been some data in ARDS patients that actually targeting 88 to 92% may be harmful. The study was published recently, but terminated early by the Data Monitoring Committee. So always very difficult to make sense of results in studies that terminate early. So there is evidence out there that going too low may be harmful, and at the same time, a sort of moderate approach may be okay, as in the ICU ROCKS study. So to bring that back to what to do in the perioperative period, I think it's very hard to know. I think what may be potentially dangerous, though, is using the ICU data to guide practice in the perioperative arena. I think they are two very separate areas, and we need to build our own evidence base in the perioperative setting to be sure we're doing the right thing for our patients.
Absolutely. Thanks, Dan. And then back to Helen for some more metabolic questions. So there's one about the metabolic effects of the ketogenic diet have some similarities to the fasting state, but may be better tolerated. Is there any evidence, do you believe, that might be beneficial perioperatively?
I'm not familiar with the literature with the ketogenic diet in the perioperative period. I think it's something that people have worried about from the point of view of ketosis, acidosis, and cardiac function and things perioperatively. But given that I'm not aware of the literature in this population, but I think that signaling-wise, it's basically the ketone bodies are part of the signaling pathway that trigger the cellular changes that increase resistance to subsequent stress. So, and very arguably better tolerated. So you could have a ketogenic diet specifically without certain amino acids, and then that could be a much more easily tolerated short or longer term preconditioning.
And Tim, a popular question about which monitors we should use for goal-directed therapy. Do you have any opinions about? We have no indirect cardiac output monitor in our hospital, this question says, other than a PA catheter. So what's your feeling about which of the many available monitors is best for this role, or do you think it doesn't really matter, just that we use them properly?
Yeah, I think the latter. I think that there's a variety of monitors available. Obviously, it's going to vary from hospital to hospital depending on your resources and what's available at the hospital and the monitor that you know. I think the most important thing is that you know how to use the monitor and that you use it well and use it appropriately. I think the technique is the most important thing. So we want to put the monitor on and then to have a background infusion of fluids, and then to give fluid boluses to optimize stroke volume and to look at 10% changes in stroke volume using that monitor, and I think that's the most important thing rather than the individual monitor. And going back to the blood pressure question you mentioned beforehand, one of the things I didn't mention, I think, just to re-emphasize, I think optimizing fluids first before we start using vasopressor is one of the key messages, and that's one of the potential unintended harms of the blood pressure literature as people start being more aggressive with vasopressors in hypovolemic patients, and that I think undoubtedly could cause harm. So put your monitor on, optimize your stroke volume, and then if you're still hypotensive, then add in a vasopressor. And using that technique, I think, is more important than which actual monitor you use.
Excellent, thanks. Any more questions as we're moving to the last couple of minutes, Mike?
Well, I've been concentrating really hard in order to get some take-homes for the end of the session, and my take-homes, and just tell me if I got it right, from Helen are that I can eat as much as I want as long as I wait 16 hours until I eat the next time and don't do it in the middle of the night. From Dan, that it's probably a good idea if I go up a mountain as long as it's not too high, but when I come back you're not quite sure how much oxygen to give me. And Tim, I can have as much fluid as I want as long as I don't put on more than a kilo in weight. Is that about right?
I think that would be pretty fair.
Okay, got it. Dennie, it's all yours.
I think you've summarised all the important information there. Just really to say thanks for a fantastic session to our three excellent speakers.
TopMedTalk. Thanks for listening to TopMedTalk. We are excited to announce the World Congress of Perioperative Medicine happening in London this year. Check it out at EBPOM.org. It will take you through to our carbon-free conference center where it has the EBPOM platform. You can find more information. Be sure to subscribe to TopMedTalk and EBPOM at ebpom.org.